I'd like to thank you for taking just a couple minutes here. We're just going to try and quickly summarize some things for the open enrollment period, which begins October 15th for the Medicare Advantage as it relates to our TMGIPA. First of all, I'll discuss this at the end, but I want to make sure that people get this information. The gap reports that we've talked about, they'll be hand-delivered to your practice, and they'll also be loaded in your ShareFile account, which is your manager's email address. Each one of your clinics has a secure, HIPAA-compliant ShareFile account, and that you can log into. And this is, if you can't remember the login, where the link is, just go to TMGIPA and click on the For Providers link, and that will allow you to access your ShareFile account. We'll be using this account to put all sensitive type information that you can upload as well back to Alignment if you wish, but this for right now will serve as a secondary communication port. But you will get those gap reports hand delivered to you, and we'll talk about that right at the end. So first of all, I'd like to say welcome to Awake Internal Medicine and Dr. Richard Abrams' group. They joined TMG, so we now have 150 plus providers in 26 clinics. And just as a reminder, if you ever need any resources, they're out at tmgipa.com. That's where all these webinars are recorded. All our resources are shared files that we look at as far as evidence-based protocols and things like that. All of that stuff is out there at tmgipa.com. So briefly, want to make sure we're all on the same page here. Medicare is broken up to 4 parts: Part A, hospital; Part B, medical; Part C, Medicare Advantage; and Part D, Medicare pharmacy benefit. We're going to mainly be talking about Part C, but it's important to understand the differences because right now a lot of patients don't understand about Medicare Advantage, and that's our goal, is to develop that market because I think we can definitely show that we can get paid more appropriately for managing these complex patients, and our patients get better care. Just a brief kind of overview. We went over this kind of last year. Of course, we have Part A, Part B here, the hospital and medical. From this, you are required to add the supplement because Medicare, remember, only pays for 80%. So you add the Medigap policy, and you also have to add your Part D. So for patients that are just taking out Medicare, they're paying for these Medicare supplements. They're paying for this Part D for that 20%. So there's definitely some cost, and they're not cheap. Those, if you look at the cost, it's to many patients' advantage, especially those on fixed incomes, to join Medicare Advantage. And this combines Part A and Part B, plus most all of the ones here in Wake County include Part D prescription drugs. So it's one price, and a lot of them have now, and you'll see it on an upcoming slide, 0 premiums. So this is a much better options. They do cover physicals as opposed to wellness exams, and they offer some other features, you know, silver sneakers, over-the-counter drugs, a lot of different things. Of course, Medigap, it's not Part B Medicare, it supplements Medicare. You know, Medicare doesn't pay for all health costs. This is called the gap. So what this coverage does is it pays the share of Medicare approved amounts that Medicare does not pay. So it does not offer benefits. It's just so it's different than Medicare Advantage. So you have to understand that basically all this pays is traditional Medicare pays the 80% and they pick up the 20%, and it's not Medicare Advantage. There's no benefits. It just supplements the cost of the original Medicare benefits. Medicare Advantage plans are 2 main types. The HMO, those are the ones that we're concentrating mainly on with Alignment. For now, Wake County, excuse me, is considered a large metro area, so all hospitals, Wake, Rex, and Duke participate. All their specialists participate. So pretty much there's no exclusions as much as there are in some other markets here, but there are some people that still aren't signed up under the HMOs, and the patients do have to go to those providers. But for the most part, almost all the specialists that you use will be on these plans. And many times they need a referral. The PPO, the patients, you know, again, they have to use the preferred providers, but they have more freedom to go on their own. They do pay a lot more for these type plans than they do for the HMOs. So this again just kind of summarizes that. Excuse me. Doctors and hospitals, Medicare supplements, you can select the doctors, and Medicare Advantage, you may be required to use doctors and network referrals. You can kind of go wherever you want, which is one of the reasons it's very difficult to control costs in MSSP and other things. But in this, sometimes you need referrals and required to use the network's referrals. There's really no restrictions on the network, but like I say, there are some in the Medicare Advantage. Medicare enrollment, like I say, we're coming up on that October 15th through December 7th. in Medicare traditional, you can enroll anytime after you turn 65. Again, in the cost, you're going to pay a monthly premium. In addition to your Part B premium, with Medicare Advantage, many times these are 0 monthly premiums. You still have to pay your Part B premium, but that's pretty minimal compared to the other costs. And then again, prescription drug coverage is not covered under traditional Medicare. So we have about 70% of our patients, 65–70%, still using traditional Medicare, when a lot of them would do a lot better in Medicare Advantage plans. So who can join an MA plan? Well, they must have Part A and B, and they must live in the plan service area. For us, that's Wake County. People with end-stage renal disease generally can't join a Medicare Advantage plan. There are some exceptions to that, but again, our service area for now is limited to Wake County residents only. So what does Medicare Advantage cover? It covers all the services original Medicare covers except hospice. Hospice always is covered by a Medicare. That's why they still have their Part A and Part B. Patients is always covered for emergency and urgent care, even when out of town, especially outside, but not outside the U.S. And Medicare does not cover it outside the U.S. either. And they offer these extra benefits such as dental care, eyeglasses, wellness programs, and may include Part D. And all the ones we talk about include Part D. It's accelerating quickly, the number of patients. I'll show you a statistic here in a second, how many patients now are moving into Medicare Advantage. Of course, we have one of the fastest growing Medicare populations in the country with about 150,000. Only about 35% are enrolled in MA plans, where in many areas of the country now that's up to 50%. So if we look at kind of the differences here from 2017 to 2018, we see the HMO market, which is the one that we've been talking about, is growing dramatically in that time period, and we're seeing a similar increase in the total number of MA patients. This is what we're dealing with this year. Of course, the three that we participate in with Alignment are First Medicare Direct and Humana. First Medicare Direct by far has the lowest out-of-pocket, 0 copays, 0 deductible. The maximum out-of-pocket is $3,400, but they have 0 deductibles for their plan. And then, of course, Humana Gold has a deductible of $4,900, which is compatible to Aetna and some of these others. But by far and away, these plans offer the best benefits for the lowest out-of-pocket, and that was just for 2018. What we have going on in 2019 is a completely different market now. We have Blue Cross coming in. But if you look at these maximum out-of-pockets, these are kind of critical values that a lot of patients look at. So we have the 2 lowest out-of-pocket plans now, Humana Gold Plus and First Medicare Direct. Patients pay 0 copays, 0 deductibles, 0 premiums. For Part D, there's, like I say, there's the 0 premium, but their maximum out-of-pocket is only $3,400. So these are the choices they're going to have this year. By far and away, I still think the First Medicare and the Humana Gold are going to be the top choices for patients, especially with the most benefits for the least out-of-pocket. So each of your clinics is going to have a broker assigned to their facility with pre-printed business cards to hand your patients. There will be MA lead cards. These cards, though, by Medicare standards, and we're going to go over this in a second, what you can and can't do. But your patients can fill these out if they want to find out. Patients are very confused about their choices. They have no idea. It's confusing for everybody. You're not allowed to really give them that advice unless they engage you. But we set up these agents so these agents can sit down with them, go over their specific needs, and come up with a plan. It may, hopefully, it's Alignment, but it may be another one. But whatever one fits their best needs. So the things we can and can't do. This is the important part of this. You must remain neutral in MA enrollment decisions, but you may engage if you're asked for advice. So that's the critical thing. You can't start the discussion, but if they engage you, you can tell them what you think. So what you can do, you can make available and distribute plan marketing materials, but you have to do that for all plans that give them to you. If asked, you can provide objective information about health plans. You're permitted to make health plan sales agent materials available in the waiting room on a resource table. You can refer to those materials, and you can advise the consumer about partnerships with the sales agents like we've talked about. You can only do these sales activities if you're going to do some sort of educational program or some sort of marketing activity. It can only be done in non-patient areas, so cafeterias, community recreation rooms, conference rooms. You can have a sales agent set up a table there if you'd like, and they can talk to your patients. Of course, we can put these lead boxes in if you'd like. Patients just fill out their name and they're contacted by an agent. Again, you can't touch those lead forms, though. They have to be sitting there for the patient, have to be in a lockbox, and the patients have to put them in themselves. Again, these contact forms can be used to collect contact information. They can be provided in these boxes, and then an agent will get in touch with them. You can also provide assistance and some information for some of your lower income subsidy patients that need help. That is allowed. And you can always share information with patients from CMS's website. What you can't do, though, is you can't steer beneficiaries to a specific plan. You cannot conduct these healthcare marketing activities in healthcare settings. Sales presentations, enrollment applications, and soliciting beneficiaries, again, cannot be done in waiting rooms, exam rooms, patient rooms, or other areas primarily intended to receive healthcare services during or after normal business hours. You cannot offer, distribute, or collect lead forms or sales appointment forms, and you cannot conduct health screening as a marketing activity. So you can't bring patients in and do a free health screening as a marketing activity for Medicare Advantage. You cannot offer to fill out the lead forms. You cannot reject requests by any contracted health plan. So if you have another health plan that wants to put the materials in, if you take one, you got to take them all. The contact data obtained from the provider contact lead cards cannot be shared with sales agents. So that's also important. And you cannot accept compensation directly or indirectly from the plan for beneficiary enrollment activities or distribute these materials, again, within that exam room setting. So you want to remain neutral if you as best you can. Do not allow a patient to give you a Medicare enrollment application. You can't make phone calls or direct or urge or attempt to persuade beneficiaries to enroll in a specific plan based on any financial or any interest for the provider. So that's also important. You cannot mail marketing materials on behalf of plan sponsors. However, we will talk about you can mail letters announcing your participation, which are approved by CMS, and those will be available if you'd like to do that. You can't offer anything of value to induce enrollees to select them as your provider, and you can't offer any inducements to persuade beneficiaries to enroll in a particular plan or organization. As well, you can't describe the plan's affiliations announcements unless approved by CMS. So we will talk about that, but we do have letters that are approved by CMS, and we can provide a free service that will mail letters to your patients announcing your participation in certain plans, and you can contact us if you want to take advantage of that. This is an example of one of the first Medicare Direct pamphlets that will be available. Again, just goes over the basics and gives them some information. And they've got a number there they can call toll free to get some information. There's some other things we'll have: flyers, brochures, there's plaques, banners. A lot of you may not want to put any of this in your waiting room because you like it nice and neat. Some of you may have a place where you'd like to put that. It's all up to you. And if you contact us, we can kind of get you in touch with the marketing people that can get you that information. So you're going to have business cards. That's the simplest way to do this. When patients ask you about Medicare Advantage, hand them one of these cards. It has the number on it. All they do is call. They leave their name. They get permission then for the agents to contact them. The agent will take it from there and go over it. We also, like I say, have the brochures, the banners, the lead box for the if they want to fill out contact information, they can do it that way if they don't want to make the phone call. Flyers and letters. But you want to try and, like I say, as best you can, utilize these resources. The business cards by far are the best, I think. This is just one of the flyers that's available. This is one of the care advisors with a long history of experience in this, and he sits down with the seniors and can go over the plan options with them. This is important. We're having these Medicare Advantage 101 seminars. Golden Corral, we're having some of them at the Lyman Health Center. Basically, these will be set up so that any of your patients that you'd like to refer that have further questions in a larger group can go to these seminars, and they will be in a presentation and go over everything they need to know about Medicare Advantage and can take advantage of that. So you can refer your patients to this listing if you'd like. This is just another example of a marketing material because, again, we're talking zero premium for these, and you get all these, you get all this great medical care, and like I say, low out-of-pocket expenses. So that number, again, for the independent agents, it's one number. You just refer your patients to that number. It then goes to a call center, which sends these out to the agents, the independent agents that are approved by Medicare, to discuss the plans with them. And that's, like I say, a pretty simple process. The patient just has to call the number. As I talked about at the beginning, we're going to make a special effort here at the end of the year for gap closure. This is extremely important for us from generating our quality standards, as well as it determines our future compensation as well. So you have to, when you get these forms for each patient, you have to schedule a face-to-face visit to kind of close these gaps. So we understand that's going to take a little bit of time, but again, for the most part, you can have your nurse, when the patient comes in, do the things that get up the information and put it in the chart if you'd like. You just have to make sure you at least go in and have a face-to-face and verify that. And some of the diagnosis codes you may have to close yourself, but the nurse can gather some of the information or set up the things that may need to be done, the colonoscopy or the mammogram or whatever for you. So again, they're going to pay $250 if you do the process correctly. And the process correctly is you're going to have that patient come in real quick, document all these gaps, document the different diagnoses, and we'll show you how to do that, and then send those forms into alignment. It's critical, though, it has to be face-to-face, and the diagnosis addressed during this calendar year. It has to be during this calendar year. So when you see some of these reports and these diagnoses, if you've already diagnosed them and already addressed it, you can use that note. You don't have to redo that. So there's three major ways to close the gap. So it's already been charted, then all you need to do is send that documentation in with the 360 form. If they've been seen within the past 45 days and you addressed it but did not document it, you can do an amendment to your previous documentation. You can send that in. But if you haven't addressed it in 2018, then the patients must be seen and the diagnosis must be addressed. The HEDIS gaps are pretty straightforward. You know, for patients with colon cancer, if they refuse the colon or they cannot get scheduled before the end of the year, give them a fit test, go through LabCorp, close that gap. Cologuard is not considered cost-effective for us, but it does close the gap. So we're looking at ages 50 to 75. Breast cancer is pretty straightforward every 2 years. You want to document that in the chart. And again, documenting a negative mammogram is fine documentation. Retinal eye exam, if they haven't had one, just simply refer them to the care center for retinal screening. They'll set this up for you. They can also get free eye exams at optometrists, and all they've got to do is call member services, and your referral person should have that number. But if not, we can get that for you. Diabetes control, it's really important that we get all our diabetics less than 9. If you have somebody that's not controlled and we need to do that before the end of the year, please just send the lab and refer them over to the care center. They have a special diabetes section that'll have the nurse educators. They'll work with them closely, make sure they can afford their medicines, and try and get that diabetes controlled under 9 before the end of the year. It's also important that there's a measure now for statins for diabetics and cardiovascular disease, and these are triple weighted in some instances. I realize there's instances where they can't take the statin. You have to document that, but for every patient where there's not a contraindication and it's appropriate that has diabetes, cardiovascular disease, we want to make sure they're on a statin. And then nephropathy screening and diabetes, of course, if they're NSAID, it doesn't apply. Otherwise, they need a urine protein yearly. Again, these are determined by Medicare. You may or may not agree with them, but this is what they measure it on, so this is what we have to go with. This is an example of the report. It's going to show some different things here. I'll break it down here in a second, but it's going to give you all the information you need. So what you're going to see here is potential conditions. Basically, we use the sophisticated software to look and say, hey, you didn't code major depressive disorder this year, but they're asking you if they've done this because somewhere along here they found that this patient got Lexapro or some antidepressive medicine. So that's what triggered this event. So you're either going to agree, disagree, or it's resolved if they no longer have it. So you want to document that. So if you have a patient on there, do they have the major depressive order, yes or no? And again, these potential conditions are all generated based on different things from labs and medicines that they've filled this year that may not have been coded. Controlling the gap for blood pressure, I'll show you this at the end, but we really need to focus on. And then here's some clinical alerts that are opened. did they have a diagnosis of COPD? These are some of the things that you need to make sure they've done. No annual flu vaccine, no depressive screen on file, no pneumovax. So these are the things we need to complete. They do give you some information of things that have been done throughout the year. They give them, so if they hadn't been done in your office, they'll have them right here handy for you so you can take a look at these. And this just shows all the prescriptions, all the diagnoses that have been coded. But it does give you some other information that makes it more easy so you don't have to go through and search the chart. So to close the gap, all you have to do is, again, like I say, heart failure. The only thing that I would caution you on is heart failure. Once you have heart failure, it is always heart failure. But sometimes people were diagnosed with heart failure that didn't really qualify as heart failure. So in this case, they disagreed with that diagnosis. This person was reported in 2017 as having heart failure, but in 2018, that was not a valid diagnosis. Same thing with peripheral vascular disease. It was coded in 17, but not in 18 yet, but they've reviewed the chart and they decided that, yes, that is a current diagnosis. They documented a current treatment plan. They've done everything they're supposed to make sure the documentation. So when you bring that patient back in, you want to make sure you code that. Again, I told you how this potential conditions work, and it gives you the reason. Because they were on Lexapro, they're asking if they had a major depressive disorder. This person didn't have any gaps, but they did have some clinical alerts, so we want to make sure we document if they had an advanced directive power of attorney. Depression screen, if it's not on file, and no pneumovax in the last 5 years, then you want to do those things. Again, these are just showing in this patient some of the diagnoses that have been coded by other providers and some of the lab results. Closing blood pressure is very important. There's different parameters. 18 to 59, it's 140 over 90. 60 to 85, 140 over 90 with a diagnosis of diabetes, and those without a diagnosis of diabetes is 150 over 90. It's the last blood pressure that you measure that's the one that they're using. So if you measure blood pressure and you're in the last quarter here of one of these patients and it's above these parameters, you want to either take it again or you want to bring them back until they get that blood pressure recorded. And it's in this range. If they have end-stage renal disease, pregnancy, or in hospice, or if you've diagnosed them with white coat syndrome, then that does exclude them from the HEDIS measure. But all blood pressures readings obtained, especially if there's more than one, they will use the lowest systolic and diastolic readings. Don't round up on manual blood pressures. If you want to get really sophisticated to show you close the gap, you can do these CPT2 codes, but you don't need to do that. But just make sure, that you're using the proper cuff size, patients are in the right position, and, the simple things that you would normally do. But sometimes, we rush to do these things and we don't get the patients in the proper position. So if it's elevated, take it twice, and educate the patients, of course, about uncontrolled blood pressure. If you have any questions for me, that's my cell phone. You can always email me or send a general one to info@tmgipa.com. Again, I appreciate you all taking a look at this tonight, and if you have any specific questions, please don't hesitate to contact me, and we can get you in touch with whoever we need to. So thanks again, and have